So the POD24 patients, or these patients that relapse within 24 months, are not overly common, but they're not uncommon as well. About 20% or maybe 25% of patients will progress within 2 years from their frontline chemoimmunotherapy. So this patient in the frontline got bendamustine or rituximab, which was a very reasonable choice and one that's commonly used, especially here in the United States. But we know that there's a large range of treatment options for these patients. They go from very conservative therapies to relatively aggressive therapies and everything in between. And it depends on the patient, the goals of the patient, the specific characteristics of the disease, in particular how fast it's growing, what the symptoms are, and what the comorbidities are of the patient, that all factor into how you're going to treat one of these patients. So you could have used radioimmunotherapy in this case. Zevalin is not specifically approved for frontline treatment, although the NCCN guidelines do recognize it as a reasonable single-agent treatment choice for patients who are medically infirmed or probably not going to be able to tolerate standard chemoimmunotherapy. Certainly, single-agent rituximab is commonly used in these patients, especially for patients who might be a little bit older or less fit. I think there are other chemoimmunotherapy regimens. R-CHOP could have been used in the front line. R-CVP is a very common regimen, and even occasionally people will use fludarabine-based regimens for these patients. And I think one of the most interesting emerging treatment choices for these patients, especially if they're a little bit older, is to move away from chemotherapy and to use what we call the R-squared regimen. It's Revlimid and rituximab. And the data that was just presented at the ASH meeting in December of 2018 really showed from the AUGMENT study that R-squared was better than single-agent rituximab from a response standpoint and from a progression-free survival standpoint. And there are lots of other choices that I certainly would consider or think about in the right patient at the right time in the frontline setting. I don't think the R-squared would have been my treatment of choice. I like that as an option for certain patients who are older who I don't like the idea of giving chemotherapy to. But in this case, I probably would have given bendamustine or rituximab. I think it's a very reasonable regimen and appropriate. An alternative, however, would have been to replace the rituximab with a drug known as obinutuzumab. It's a newer generation humanized anti-CD20 antibody and results from a couple trials, the Catalan trial and the Gallium trial. Both show significant improvements of adding obinutuzumab to bendamustine, either compared to bendamustine alone or compared to regimens of rituximab-based chemoimmunotherapy.